So any questions are welcomed. Microphones are at the stairs.
What percentage of patients would you say that show up end up being good surgical candidates?
I would say we turn away 80%.
What's the number one reason that you're turning them away for?
And it's a variety of things. Oftentimes, it is a systemic issue. Even though, so our cutoff actually is 35 for surgery, but we bring in patients up to 40 just to counsel them. So it's a combination of those issues that we identified before.
Yeah, so we also screen the patients before they come. We have them answer a whole list of questions and send their photos, and we screen. And I say about half the time we will say you're probably not a candidate because of various reasons. And then when we see them, even within that group, there will be a certain percentage of patients who are just not a good candidate for a number of reasons that we talked about. I don't know exactly what percentage it will be, but it's not like everybody who walks in the door are going to be being operated on. I think it's very, and also it is patients, you have to be clear about the expectations, and once they find out what the expectations are, some of them may not want to undergo surgery. So it's not everybody who walks in who's going to be operated on.
Yeah, and I would just echo that. I think expectations are really important. Making sure your surgery can match those expectations, that's probably the number one cost.
So my question is about air travel.
Are you certain?
I've had many patients where that was either the instigator or the thing that made it worse, that they had it under control, but they couldn't wear their concussion garment. And I've seen it many times.
So I know a lot of our faculty are the same thing, but about 75% of my patients come from outside Chicago. They fly in, and then they fly back home. And I don't recall, and they always ask that question, what about, how am I going to get back home? Can I travel back? Do I have to? And I do not recall anybody saying, when I flew back home, it got worse or anything like that. And I think Dr. Slavin's, what he mentioned is accurate. There's no study that demonstrates that all these things that people have talked about are supported by any scientific data. So I think you have to let them know. Well, if you feel comfortable, wear the garment, have it wrapped. But I'm sure there's nothing there to support that. Are any issues with it. You just have to tell them like it is.
But is there a study that also says that it doesn't occur? Like, do you have a study that says, that has watched and seen that I'd like to, that a flight doesn't? Because it's still anecdotal. You're saying, oh, well, I have it. But for a lot of patients, it's not the first time. And for the same reason why we still don't understand why patients with sentinel node biopsy get developing lymphedema. Well, we see it. We know that it's happening. Well, if somebody's flying over the course of years, it can happen. So why? Is there a study that shows that it couldn't?
Bob gave a talk where he looked at different these questions and had a different type of papers. I don't know if there was a paper that kind of looked at it and found that there was no correlation, really. But I do tell the patients I do tell the patients that if you, everyone's a little bit different. So if you've had a history of every time you travel, your arm gets big, or the patient always also mentions this as well. In the summertime when it gets hot, my arm swells up. So if they say that, then I say, well, then wear the garment. And but the studies have no strong correlations to demonstrate any of these are true. And if you are having surgery and anesthesia, and they're not going to stick an IV in there, or they're not going to do that just because of all the things we've heard. So then don't do it. We don't want them to do it and then be sitting there wondering, oh my God, it's going to get worse now because of this and that. So I think being careful is good. And all those things. But I also try to share with them their fear may just be a fear based on myth rather than scientific data.
We have one gentleman up there who is waiting to put a question.
Thank you for some great talks. So one of my concerns in moving this field forward, and congratulations on what you've done here at Harvard, is really the financial issues in terms of funding and how to make this happen. And where I practice in the Bronx at Montefiore, we have a lot of underserved patients with lymphedema. And part of the reason I'm here, besides speaking, is really to learn about how to build our program from the experts. But I think, some strategy moving forward in terms of compensation and financing the imaging workup and the surgical procedures. It's hard enough. There are patients still who can't get garments because of financial issues. So I just wanted to throw it out. This may not be the right exact session to discuss that, but I'd like your comments and thoughts about it. Thank you.
So when I was at the University of Florida, in all the transplants we did, we only had one MRI in the workup that wasn't covered. And we just ate the cost of it, the institution did. We've had a little more of a pushback here in Massachusetts, but for our institution, Beth Israel, they made a commitment to this. So I personally write letters. We're in third and fourth round denials for the lymph node transplants we've done probably in the last year. But we're going to keep fighting the fight because the data is getting clearer that we are helping patients. And so it's really important. And it was a big part of my recruitment here was I needed to make sure the institution was behind it, and they are here.
Yeah, as I mentioned in my talk, all my patients get insurance approved first before I schedule them. And not all of them have great insurances. I practice in Southside Chicago, and which is pretty similar to Bronx. And there are patients who don't have the best insurances, and a lot of the like lymph node transplant are often covered. Actually, the reimbursement might be very low, but they're covered, and as long as they're covered, then that's one of the things we do is to serve the community. So we do them, and maybe hospital takes a little bit of a hit, but it is what it is.
I do think that in regards to the question about air travel and needle sticks, that it is a very difficult thing to study, and many of these anecdotal cases don't get reported, and therefore I think trying to draw conclusions based on the data is still challenging. I mean, I have also personally seen, I had a patient got a sub-Q heparin injection in the arm that she had an axillary dissection on, developed literally lymphedema the next day, and it took months to get the arm back down. There are conditions and settings that may exacerbate lymphedema, as you mentioned, David. Heat. Often, many patients that live in the South complain about it, or people that go down south during, live up north but travel down south. They have trouble when it starts getting hot. So these may not cause permanent damage, but they may exacerbate symptoms and may also be the initial trigger, as we say. So I think the distinction between what's going to harm the lymphatics versus what may make patients symptomatic is also important. And I think patients can get symptomatic flying, but it may not actually be causing permanent harm, and it may be unmasking, subclinical lymphedema in certain cases. So I think that question is a little more complicated than we sometimes, think about it, and I just want to make that distinction.
What you say is very true. I think there are a lot of things that the patients read about and they know, and what I try to tell them is that I think those are concerns, and I think you have to be very careful, all those things. But just also let them know that these are just, there has not been any studies to support one way or the other. So just have to give them the information. But being cautious with lymphedema, I think is important because you are prone to getting infections and things like that. So I always tell them, if you're gardening, make sure you don't cut yourself. If you have pets, make sure your pets are not scratching all over your arm. All those things, just to be cautious, because once you get infection and everything below, and then you get that exacerbation of lymphedema, it's very hard to manage. So I think being cautious, there's nothing wrong with that. But they also need to understand that there is really no scientific strong data to support one way or the other. It might be true, though.
Okay, final question. Catherine Cyril.
Thank you. As a patient, first I want to say thank you. You guys are the trailblazers. And as I'm standing here, it is a little bit Druve of pixie fairy dust because the fact that we're all having this conversation is going to move it forward. So as an advocate, I'd like to ask you, since lipidema is so often misdiagnosed as lymphedema, and in its advanced stages shows up as lipolymphedema, so a lot of patients show up in your clinics who might have this dual diagnosis. What are you all doing to move that forward?
So this is a tough topic. Our lymphedema program got so busy that our clinic is full into February, and I had to shut down the lipidema side of things because we just didn't have the manpower. And so what I've told the lipedema patients that have come through is that I'm dedicated to be their advocate, and as this program builds, to figure out how we can accommodate lipedema into our program. But currently, we just don't have the resources for it. But yes, there's a need. I've seen these patients. For us, we're just not ready to address it, because it has to be addressed responsibly.
Yes. There are 17 million women in the U.S. who have lipedema, and many of them have lipolymphedema. There is one doctor in Boston at Mount Auburn Hospital who can diagnose. How are we going to make something happen?
Again, I think with continued advocacy and, it's important. We need to have the patients need to be heard. It's why we're having the patient symposium. And as you know, we're including lipedema in that, because the more we conglomerate the patients together, the more we're going to move all of this forward, for sure.
Mm-hmm. So I'm a pretty strong advocate, I apologize. But who here is willing in the Boston area to actually start working with us? So I'm just putting that out. Boston, Chicago, Taiwan, somewhere.
Yeah.
It's a population that needs to be addressed.
Completely agreed. Time.
Okay, thank you.
Time.
We need to move on
Yes.
to the next session. Thank you very much.